Okay, so we are back with Dr. Cook, MindMomBodyRN Season 2. Thank you for coming back.
My pleasure.
Did you have anything that you wanted to specifically say to the trolls that came after you about safe sleep?
No, because I didn't actually read anything that they said. You just told me they trolled me.
I know. Okay, that's true. That's fair enough. So today, a reminder, Dr. Cook, can you give like a brief background, what you do, who you are?
Pediatrician. I went to med school at Medical College, Wisconsin, residency at Cleveland Clinic, had a couple of practices, and one in Ohio and then in Chicago before moving here to the Twin Cities in about 2010. Practice general pediatrics.
All right. Well, thanks for being back.
Like I said, my pleasure.
So today, our big topic is, surprise, surprise to everyone else that has been watching this season, postpartum depression. So, as much as as you and I like to joke around, this is like, we're kind of talking about the gravity of it. Mm-hmm. Can you kind of talk a little bit about physiologically what that looks like when postpartum depression takes place?
Sure. First, I'm going to back up. Yeah, I'm going to back up a little bit. Postpartum depression, now often referred to as peripartum. Depression is can occur not just after delivery, but before while you're pregnant as well. You can divide that up into sort of three categories or three severities. One is just baby blues. This is fairly normal. This is a fairly normal experience. Very common experience, and not at all dangerous. The second is postpartum depression or peripartum depression, where the symptoms become more severe, and I'll get back into that. Mm-hmm. And then the third is postpartum psychosis, which is a very dangerous situation and generally an emergency.
Can you speak to how they can escalate into that if not treated? You'll get into it.
Yeah. But first, before jumping right into it, let's go into more like the symptoms, the symptoms of it. So baby blues is just a generally occurs right away within the first few days, after delivering. Some feelings of sadness and irritability, maybe not sleeping well, maybe having trouble focusing. You might be questioning yourself as, am I a good mother? Am I a good person? Am I a good partner? But the symptoms tend to last a couple of weeks, a couple of weeks at most. They tend to be fairly mild in the grand scheme of things, and then resolve. A woman's body goes through a lot when they deliver a baby. Levels of estrogen and progesterone are really high. Yeah. And then after delivery, they drop quickly. They drop really precipitously. And thyroid hormone does the same, does the same thing. So your thyroid hormone when you're pregnant is high. Mm-hmm. It's just part of pregnancy, and then it drops fairly quickly, after delivery. And these changes put a lot of stress, on you. And also you're not sleeping. You have a newborn baby, and it doesn't matter whether you've delivered a baby or not. If you sleep like a new mother, you are not going to feel right. Right. If you wake up every 2 to 3 hours, whether or not you're actually feeding a baby or you just have to wake up every 2 to 3 hours for any reason. Yes, they had high sleep trolls, right? If you don't, if you're not sleeping properly, you're not going to feel, you are not going to feel good. And this is all sort of part of the normal the baby blues can be considered sort of almost as sort of part of the normal process of delivering and of having a baby. Now, when you start to move into the realm of postpartum depression, the symptoms get a lot more severe, and they last longer. They don't resolve quickly. To diagnose postpartum depression, you need to have symptoms of depression that are interfering with your ability to function. This could be profound sadness. It can be a sense of helplessness, a sense of worthlessness, and what we call anhedonia, meaning no pleasure. You don't have any pleasure in doing anything, and avolition or avolition, meaning you don't have any desire, any desire to do anything. You don't have any drive, any initiative, to actually get things, done. You can have physical pain, headaches, abdominal pain, general muscle aches, muscle aches and body aches. Sleep is disrupted, not just because you have an infant, who needs to feed every 2 to 3 hours, but oftentimes insomnia, where you can't go to sleep, or you have incredible trouble, falling asleep, or you're sleeping too much. You can become sort of agitated, and aggressive and lash out at people, or you can become withdrawn. And the worst symptoms, of course, are thoughts of homicide and thoughts of suicide, thoughts of killing yourself or thoughts of killing other people, and that can include your baby. Then you move into, from that, you can move into then postpartum psychosis. Back to postpartum depression. The symptoms have to last for at least 4 weeks, for that, and be severe enough to interfere with your ability, to significantly interfere with your ability to function. And then you move into postpartum psychosis, which can occur, at any point, but usually occurs a little bit later, after around about 4 weeks, or so. Psychosis, you can get delusions where you believe bizarre things, you believe things that aren't true, things like, people are inserting thoughts into your mind, or the Amazon guy who just dropped off a package is, really dropping off surveillance equipment, for the government. And paranoia, is a big one with that. And you can hallucinate, you can hear things that aren't there, see things that aren't there, less commonly even smell things and feel things that don't, that don't exist. And some of the biggest dangers with this is you can also become manic, where you have a tremendous amount of energy, and you get this tremendous amount of energy while you're thinking about hurting yourself or hurting somebody, hurting somebody else, and that you can follow through. You can follow through with that. And postpartum psychosis is almost always a true, emergency, and seek help, right away. And it's also not subtle. For anyone who is around someone who is having, an episode like this, it's not subtle, and generally people will seek help for it. And so that's just sort of the background of the symptoms. You'd asked about physiology and brain chemistry and the like. Yeah.
Before you touch on that, could you kind of talk about, specific to motherhood, what those internal thoughts and voices and ideas might be? Because it's different for just the average person. So, postpartum depression has a lot of similarities to depression of other sorts, but there are also, differences as well. And I think what you're asking is sort of emotionally, the thoughts that are going through your mind are, I'm not a good mother. I'm never going to succeed. My baby's not going to love me. It might be the changes in your body. I'm no longer attractive. My partner is going to leave me. It may be things, like, I can't breastfeed, because my milk is worthless. Everyone has a little bit of trouble breastfeeding in the first, first few days. And it's often frustrating, in the first few days, but, it goes a lot deeper, a lot deeper than that. Sometimes it's, focused on, more career. It's like, what have I done? I'm never going to get hired back on, I got hired back onto my job after maternity, after like an
maternity
identity.
leave. And so all these thoughts of when I say the general thoughts of worthlessness and hopelessness, and sadness, the specifics of that are generally, and they can be anything, but in postpartum depression are often, focused on being a mother, and that's particularly hard because that's what you've wanted. Right. I mean, most pregnancies are wanted, or wanted pregnancies, and it can be particularly difficult. I think, did I answer the question that you were asking?
Yeah, I wanted to kind of touch more on, I guess I'll just speak to some of the thoughts that are kind of carry a lot of shame that I can speak for myself. Like, what if I don't love my baby?
Yeah.
I don't feel anything towards my baby.
Yep.
Is this really my baby? I don't even feel like we're connecting.
Yeah.
And in terms of like it presenting with anger, you can have these mood swings of like, I am so fucking pissed and I'm seeing red and like I'm lashing out at my partner. They didn't do anything, you know, but like the anger can present. And as women, I think that we're often like, she's just going to be sad. But no, like if you're raging and pissed out of control, that can happen too. It's if you're not feeling like, I remember, and I'm sure you see a lot of patients, but I came to your office with Kendall, my middleist, and I said like, I don't even feel connected to her. Like this is nothing like my first experience. So I just wanted to like kind of give that those thoughts are normal too. And
those are all common thoughts in postpartum. You know, in postpartum depression. And you know, baby blues, you have a little bit of it. You know, but you work through it, and you can still sort of recognize that, you know, there's a light at the end of the tunnel, and hopefully your medical providers or family has told you this might happen. You know, that, you know, you feel you feel a little bit sad, but it can get really, you know, deep and profound with, you know, with postpartum depression. And so what's going on physiologically? So these hormone levels, right? You know, estrogen, progesterone go way up. This then, and this is all kind of relatively new stuff, but it's, you know, the woman's brain changes dramatically throughout pregnancy, you know, and then with delivery, and then after delivering the baby, it, you know, can slowly return to its pre-pregnancy state. Some changes, you know, kind of reverse over about 6 months. Others take a couple of years, you know, to reverse. And, you know, the thought about this is it's hard to raise one of these guys, right? It's hard to raise a baby. I mean, they don't really give anything back, you know, in the first couple of months. All they do is they eat, sleep, poop, and cry. And they don't even smile at you, you know, for a few weeks, right? And, you know, the idea behind these changes is to prepare, you know, someone to, well, have, to care for a baby, to move away from just caring for yourself to keeping somebody else alive, you know, with everything that you are. And these are important, you know, these are important changes, and women who go when you measure them with the MRI, these changes are less, they actually sometimes feel less bonding, you know, with the baby. And
that's with a brain scan.
With fMRIs, and, you know, these, with
well, a lot of our audience, I didn't know if they knew what an MRI was, so I just want to say,
brain scans, with brain scans, and but this leaves women particularly vulnerable to depression and anxiety and psychosis, because all these rapid changes are occurring. And, you know, you talk about feelings of guilt and shame, you know, with it, because when you have depression, I mean, you're dealing with some physical stuff, but you're dealing with your emotions, and then you feel guilt, you feel shame, you feel like, well, this is weakness. And symptoms of depression are, you know, thinking that you're not worthy, and then you feel that you're a bad person for feeling that you're not, you know, for having these feelings that you're not worthy. But what would happen if, you know, you had a breach, you know, your baby's breech, and you needed a C-section? And maybe some people would feel like they were a failure, but, you know, you don't usually feel like you're a failure because, well, baby's backwards, so we needed to get them out different. You know, right? Right. There's a complication of pregnancy. Yeah. It's the same thing with this postpartum, you know, with this postpartum depression. It's a complication of pregnancy. Something didn't quite go right, and it's not your fault, you know, that it's happening, and it's not a weakness or any sort of personal flaw, you know. It's a complication of having a baby, and it is very, very treatable. Right. So
before we get into treatment, could you kind of speak to to some of the thoughts we talked about kind of the depression thoughts. What would those thoughts look like when we move into psychosis? So we talk about like
bizarre.
Yeah.
So it's not just the sadness and depression. It's more bizarre beliefs. Like literally, you think the Amazon guy is planting a bomb on your doorstep, and you think that you literally think the baby is not a pod or something.
Right.
They can be very bizarre, and you can hear voices. Sometimes just mumblings and vague, and vague things.
Can you say something like maybe a mom might specifically hear in psychosis? Like, because we talk about...
Sure.
Yeah.
I guess I never treated postpartum psychosis.
Right.
But, I just in general... these voices would say something like, you're such a bad person. You need to, hurt yourself. You need to feed your baby something. That's going to hurt them.
Or, the devil's trying to get my baby.
Devil's trying to get your baby, or, your romantic partner is trying to kill your baby, is trying to hurt your baby. So you might need to go after them. So, particularly if you're hearing voices that are telling you to do things, we call these command hallucinations. If these voices are commanding you to do things, like
if you don't stay awake, your baby's going to stop breathing.
Yes, that could be psychosis. That could also be an internal voice of depression. It's very hard, to describe what someone experiences when they are, they are hallucinating. So that could be an external voice that is not your own, that is not your own voice commanding you to do this and telling you to do this. That could also be your own internal dialogue gone wrong.
Right.
So it's tricky sometimes to tease that out, but either one is a big problem.
Right. And to a spiritual person, or maybe to somebody that has is very religiously inclined, the voices can feel very real, and it can feel like God is speaking to me, but
to atheists, those voices sound really real.
Right.
They don't put it in terms of God, but those voices are very real, to people who are experiencing them. Absolutely. Right. And that's a good point. It's difficult, when you're not hallucinating, when you're not hearing voices, it's difficult to understand what this, what this experience is. Like, well, why don't you just ignore them?
Right.
I mean, that's this whole field of psychiatry and psychology, trying to get people to, to not listen. I mean, how many people out there can just don't listen to what they think?
Right.
I mean, it's really like telling yourself, don't listen to what you think.
And sometimes we have passing thoughts, and I don't even know if this is related to depression, but passing thoughts like, I'm giving my baby a bath, and it's like, if I let go right now, they could be gone. You know what I mean?
So some of that can be protective.
Right. Yeah.
Do you think about that when you drink a coffee? No. And how often do you drop a coffee mug?
That's true.
So do you think about that when you bathe in your house? Most people don't drop their babies very often. People drop coffee mugs and dishes all the time because you're not thinking about, so some of that can be protective, but then as I said, it can go bad.
When it's disrupting your life.
When it can disrupt normal functioning. I mean, part of being a parent is don't drop your baby, keep your baby safe. Like I said, they're hard to keep alive, sometimes. But when it gets to the point that it's no longer useful, that it's no longer helpful, that it's no longer protective, that it might actually be interfering, with your relationship. Like you said, if you're not sleeping because you have to stay awake all day and watch over your baby so that they don't, so that so you can they don't stop, so they don't stop breathing. It's another example of how that process can go very wrong.
And then I think if we could kind of talk about treatments, if we could talk about the Red Leaf Center, the different options.
So I want to go back to do you want to risk factors? Or
let's do that and treatment.
So risk factors first. So Risk factors, if you're a young mother, more risk if there's, you have a history of depression of any sort, whether it's major depressive disorder, or a history of anxiety, or prior pregnancy where you've had postpartum or peripartum depression, that puts you at higher risk. Stress will put you at higher risk, and that could be any sort of stress. If things that are more well recognized, or poverty, domestic violence, or any sort of violence, any sort of violence, I suppose, puts you at risk. If there's something unexpected about your baby, your baby has special needs or medical diagnosis, and surprise twins. If you got ultrasound, then you're not going to get surprise twins, but a lot of people don't get prenatal care, and there's twins. If there's something surprising or some complication, with the pregnancy, that can put you at higher risk. At higher risk as well.
Yeah, or you could have none of those risk factors and still get it.
It's just So about.
But knowing more like where our population, right.
Ethnicity, race can put you at higher risk. White women have lower rates. But oh God, don't quote me, trolls. I think Latina women have higher rates, the highest, rates in the U.S. of postpartum depression. And I think on average about 12 to 15%, of everyone with, and differing rates based on race and ethnicity as well. Sorry, you were asking something?
No, so let's talk about treatments. So treatments. I come into your office and I just had a baby. What does that look like usually, like to you? How do you identify that? So
screening, like how do you diagnose it before you before you treat it? Because it's not really common for a woman to come in and say, I'm having depression symptoms. Because there is a lot of guilt, there is a lot of shame, and they don't know, am I having the baby? Am I just having baby blues, and I'm just.
And it's unless you really trust your provider, it's very embarrassing to say, like, I don't feel right.
Yeah, that's common in this. And so we have screening tests, questionnaires, you filled them out.
Right. The EDPS. Yeah. And it is much easier that's such a good conversation starter. For you to be able to look at that and be like, Mom, I see that you're not feeling so well.
Right.
Yeah.
Right. It's that is often a lot easier than just asking. Mm-hmm. Just asking the questions.
How you doing? Good. Right. Yeah.
Right. So there are some very good screening tools. And even though as a pediatrician, I don't treat mother for postpartum depression, I'm seeing you more than your OB is. Right?
Yeah.
Is I'm seeing you a lot for just see the baby in the hospital. You see the baby when they're 1 week, 1 month, 2 months. So I'm seeing you a lot.
And that doesn't include all the visits in between where it's like, I need a weight check. They have a runny nose. What do we? Yeah. So we do see you way more than our own care providers.
Yeah, and so we do these. We'll do screenings. And then if identify it, start a conversation, and then refer you on to your own provider, or I can help to. If you don't have a medical provider, I can help find someone. I find someone to help you. To help you out. But treatments, I can't talk about treatments in general. I treat a lot of depression, in children, and the treatments can be very, similar. And first thing is just counseling. Is therapy. Sometimes that's enough, particularly for mild. For mild symptoms. Psychiatric societies will recommend that first for mild. For mild
first
symptoms.
Line.
Yeah. And there's a lot of different types of therapy that might be useful. As CBT, cognitive behavioral therapy, which tries to get rid of the bad thoughts, turn these bad thoughts into something more, into something more positive. ACT or acceptance and commitment therapy, which a little bit different take on it, where you just recognize that these bad thoughts are going to be there. Don't let them control you, get some higher control over these, over these depressed thoughts. Sort of a family therapy, family therapy or interpersonal therapy helps you to, build relationships with those around you that can be, that can be useful. One of the few things that is really protective against suicide is having a good support group, even more so than Prozac, is having a good support group. And so that type of therapy helps you to build these positive bonds. And there's others too. I mean, but there are a lot of different types of talk therapy that can help.
Second line. Well, so we try therapy.
That also, even before, take care of yourself,
self-care.
Take care of yourself. And sometimes you can't if you're depressed. That's one of the, sometimes you're so depressed, you're not showering or eating properly. But in milder situations, make sure you take care of yourself. It's going to be hard because you have a baby and there's not much. Go outside, take a walk, get a little bit of exercise. Make sure that you're sleeping properly, call upon your support system so you can get a good night's rest and have someone, someone take care of the baby, feed baby overnight, for you so that you can sleep and rest. That's very important. That can be very important as well. And then medications. A lot of different kinds of antidepressant medications can be used safely while you're breastfeeding. There are SSRIs. I don't know. Do you want me to go?
No, we don't have
list,
to go through
list all
all
the
that.
meds and all this.
There's we just know that there are medications that are available.
There's a lot of many different types of very good antidepressant medications that can be used safely during nursing, as well as safely during pregnancy. If you have depression symptoms before you deliver, that's often the mainstay, of treatment for anything other than mild, postpartum depression. If you're moving into the arena of psychosis, if you're moving to the arena of postpartum psychosis, you may need to be admitted, for a short time in order to stabilize, in order to stabilize you, to keep you safe from yourself, and your family, and your family safe as well.
And to get better.
Yeah. Oftentimes these are not long stays. They're short stays just to stabilize you until you feel, until you feel safe. And after that point, you can go back to your routine and probably on some medications, medications for it.
What advice might you have? What encouragement might you have as a dad and also as a pediatrician to someone who has a partner, their wife, their whatever is struggling with this? Yeah. Because a lot of times, I want to help. I don't know what to do. What are some things they can do?
Yes. First, partners can actually get depression. As well during this as well. And we've been focusing only on, only on the mothers who's delivered. Yeah. And there are some differences, but partners can get this as well. Fathers, can get this as well. And the rates are lower, but you can get up to 10%, and
if mom has it, partner is more likely to have it.
Yes, yeah. You can get up to 10% of co-parents, fathers or otherwise that can then get depressed also, even though the hormone changes aren't there. You brain scan a woman with postpartum depression, their brain looks one way. You brain scan someone with major depressive disorder, it looks a little bit, it looks a little bit different. It's still very stressful. It's still a very stressful event. So unfortunately, we don't screen partners, for this. We only screen the mothers, who delivered, which might be a mistake. But partners can get it, as well, and the outcomes for the infants, for the children are worse. If you have two partners. If you have both, presuming just two parents, right? It's most of the U.S. But if you have two parents that are both depressed, outcomes are worse. If you have a single parent, outcomes are worse. If the depression isn't treated. If you have one parent that is depressed and the other who isn't, outcomes are a bit better. For the children, for the kids, outcomes are a bit better for the kids. And we talk about so with the children.
No, but can we talk about partners too?
Yeah, right. So I'm going all over the place. So partners can be depressed. Partners can be depressed as well. So that's also something to recognize. Oh, you'd ask me what can a partner do?
Yeah.
What can a partner do? First, recognize that this is an illness. That this is not personal.
They're not choosing this.
Right. Yeah. They haven't. Changed their mind. And it's and it needs to be treated. Treated as such. Help with self-care. Help a lot with self-care. Stay up at night. And feed the baby. Express breast milk or formula, whatever you're using. Let mom get some sleep. Let mom go out and take, and take a walk, and do those self-cares. Take a lead in being sure that the mom and the baby are going to appointments, and getting care. First and foremost, if you think there's postpartum depression, in your partner, or any sort of depression in your partner, but postpartum depression in your partner, go to an appointment. Go get an evaluation. Get an evaluation for it, and make sure you keep the appointments. One of the symptoms, you say avolition, no motivation to do anything, and fatigue, and excessive sleep. Just stay home and you miss your, and you miss your appointments. So make sure that's happening, and just be supportive in whatever, in whatever it is that you need, whether that's making sure you take your pills put your pills every morning, feeding the baby. Yeah. And if you're from, a child care perspective, make sure that you are interacting with your child. So postpartum depression doesn't just affect the mother, or the partner, but it also has consequences for child development. Children don't develop in a vacuum, right? Children need to interact with the world in order to develop properly. And this starts, of course, with interacting with their parents. If you are depressed, you don't interact right. Depression can tear partners apart, because it's, and if you don't recognize that this, and treat it properly, it can feel very personal. When you lash out, at someone, what's your first reaction if someone lashes out at you?
Defensiveness.
Yeah, right. You get defensiveness. You get defensive about it
and retaliate sometimes.
Yeah, exactly. And maybe you withdraw. Maybe you lash out. Yeah, you retaliate and lash out back. And that doesn't help. That doesn't help. So interact with your baby. Make sure that you're making eye contact and feeding them and changing them and getting their needs met. Is if you don't, so if the baby interacts with someone who is depressed, that is different. Mm-hmm. And there are measurable changes in intellect, in attention span, in behavior, in development, and speech development, and really all forms of development, mostly speech, but, there are measurable adverse outcomes, if the depression isn't treated, because the baby's development is not going to be optimal.
So what would your response be to somebody who said, like, well, yeah, she's depressed, but they're just a baby. They don't know any better?
I'm sorry, I don't
So
understand.
What would you say? Let's say a husband said to you, like, yes, my wife's depressed.
Yeah.
But, it doesn't affect the baby. They don't know any better.
Oh, I see. I would tell them just that. Just what
right.
I just
On the
said.
contrary,
it really does. Or it has the potential to. It has the potential to. And it's interesting. You get this sort of dose effect. So if both partners are depressed, you get worse outcomes. Yeah. If you have a single mom who is depressed, you get worse outcomes. But if you have one partner who's depressed and the other who's not, you get a bit better. You get better outcomes. You get developmentally better outcomes in the baby, because you have someone who is interacting. who is interacting with them. So it absolutely makes a difference. And no, the baby can't, intellectualize, and say, yes, Father, I know my mother's depressed. It's okay. No, of course not. Of course not. But the way that the baby interacts with the world is huge. Right. I mean, just take it to an extreme. You just stick a baby in the crib and don't feed him, don't change him. You get bad.
Really bad.
You can get bad outcomes. And if you're not looking at your baby, yeah. But what if the baby is looking at you and you look away every time? What if you never smile? And what if a mother might sort of interrupt. What will happen is you don't get this duality where mother's schedule and baby's schedule sort of merge together. Mom gets sleep when the baby gets sleep. Baby wakes up, you nurse, and it feels good. You get the oxytocin, and you fall back asleep. Mm-hmm. And you don't get into this. You don't get into this routine. Baby wakes up, and the mom is angry because because of depression. You feel that the baby is lashing out. Is lashing out at you.
Yeah, you're screaming. You're doing this to me on purpose. I'm. Yeah.
Yeah. Or you're just thinking that,
right.
Or you're just resentful, and you don't interact with the baby. Or on the other hand, you get a baby who is crying because they need to be changed and they need to be fed, and you ignore them. And the mother ignores them again because of depression. So the baby then learns, I'm not going to get my needs met.
Right.
And they form these fragile attachments, and they don't form attachments properly.
I heard it worded really well once, and it was like, when babies stop crying at a certain age, right? Like, it's not because they've learned to self-soothe. And I'm talking younger babies, babies. It's because they realize no one's coming.
Yeah. Yeah, I mean that in bad severe cases that can happen. That can happen. That's what we're trying to avoid, and that's really when it's taken to its worst. Well, worst extreme is baby doesn't survive, but from a developmental perspective. That's sort of the worst possible, possible outcome at that young age. But there are degrees, there are absolutely degrees of that.
Everything's a spectrum, because that's not to say too, if you feel like you're about to lose it and baby's been screaming, you're perfectly fine to lay fed, cleaned baby that you've tried to soothe and you're about to lose it in their crib, and you take a break.
Yeah. Of course.
It goes on totally both ends of the spectrum.
Of course. And I guess said at the outset, babies are hard, and the babies, they're amazing, they're wonderful, but they're hard. And there's a difference between sort of this, normal frustration. It's like, okay, I need to take a break. I don't have anyone here, to help me right now. So I'm just gonna let the baby cry for a little bit so that I can take a shower, baby in the crib in a safe space, go do your self-cares, come back. That's fine. Mm-hmm. There's a difference between that and never meeting the baby's, and meeting the baby's needs, or barely meeting the baby's, or barely meeting the baby's, needs, and so like you said, it's all a spectrum, and these normal baby blues, these normal experiences that can merge into depression, and there's no really merging into psychosis. That's boom, you see it, but. And that's why it's important to screen for this, and if and to go to your appointments and get help if you think you might need it.
So the other thing that we were going to talk about, or that I wanted to address, was just when you are depressed, like babies love us to be mirrors. Naturally, mothers are supposed to mirror what the baby is. If the baby's sad and crying, the mother kind of mirrors that expression. So I just wanted to add in there that part of what they teach with like the attachment portion in like with postpartum depression is even just engaging your baby and trying to hold that eye contact and trying to mirror what they're doing. Even if you're fake smiling and mirroring it back, that makes such a difference.
Yes, it can. It can even give you some positive feedback.
Right.
Yes, some positive feedback as well.
But being conscious of that, even like with when you're in your depression, I remember with Kendall, like you telling me, like consciously, like smile at her, try to delight in your baby.
Yeah.
as much as you can.
Read to her, sing to her, enjoy, enjoy her.
Yeah. And I remember you saying to me, you're like, I don't care if you read her Stephen King. Like, just.
Did I say that?
Yeah, it was something
that sounds
like that.
Something I would say. Yeah.
But just that,
just don't read Lovecraft if they're not ready for the H.P. Lovecraft.
I don't even know what that is. What is that?
Cthulhu.
I don't know what that is.
No, okay.
Okay. Will the trolls tell me? No, I'm just kidding.
Sure.
And then before we did your dadity, I did want to kind of take a moment to talk about where does it go when it's not treated? Where in your career have you seen where this can go left untreated?
Infanticide.
And can you explain what that
killing your baby?
Yeah.
I mean that's where it can. That's where it can go. It's not common, but that's where it can go, and suicide,
right?
And it can go when in suicide.
Yeah,
that's where
that's
the potential. Yeah, that's the potential.
Right.
That's the potential for this. Yeah.
And that's why we want to get on it and address it early.
If you think you may have postpartum depression, please get help. It's okay to get help. This is not a weakness. It's not a personality. It's not a personality flaw. It's a complication of pregnancy, and it's a complication of delivering a baby. Just like if you were to be bleeding, a few days after delivery, you wouldn't just sit on that, in right. guilt and shame. You would go, and seek help. Think of it in those terms. I find that to be helpful, and it is absolutely okay to get help. Look to your healthcare provider. Look to your partner. There are a lot of a lot of people out there, that can help you out. Suicide hotline, of course. If you're contemplating hurting yourself, contemplating killing yourself, suicide hotline is the thing to use.
Yeah, perfect. Thank you.
Yeah.
Could you, before we wrap it up, share your dadity?
Daddy, that's a funny story about being a father, right? So, all right. So we're talking about child development.
Yeah.
Yeah. So my youngest child, I don't remember how old they were. They were two and a half, something like that. 2.5, I think. They weren't talking very much. And I was worried that, maybe there's something wrong, and they should be talking more. They seem to be a bright kid, and everything else seemed to be going well, and they could communicate in other ways that were not verbal. But I was starting to get concerned, and I was giving them a bath, and they were taking a bath with their sibling, and had a little bucket you're supposed to be to pour on the hair. It has like a little flange on there so it doesn't get in your eyes.
Yeah, right? We have those.
Yeah, right. So they're taking a bucket and they're pouring it out of the bathtub, just staring at me. Like, what are you gonna do? Just kidding. I took the bucket, poured it out, and it just stared at me. What are you gonna do? And of course, I told them, no, don't do that. And stop, don't do that. And then they did it again. They were just staring at me, took a bucket. And so I was a little more stern, right?
It's so relatable, yeah.
I was like, stop, don't do that. So they stood up with the bucket, threw the bucket down and pointed at me and said, "Daddy, don't tell me what to do." Exactly. That's exactly what I was doing on the inside. So, but I had to keep I kept my sternest face, right there. And like, I'm thinking, oh, well, wow, if that was me, I'd be whooped right now. Don't do that. But so I kept my sternest face, and I didn't say anything. I just tried to blank face them. This took 10 seconds of a stare down, and I am so cracking up on the inside. And I'm thinking, I can't hold it. I can't hold it. They eventually realized their error, sat back down very calmly. And I left the room. I went to the bedroom. I put my pillow on my face and I laughed as hard as I could. I laughed as hard as I could at that. And I knew at that point, they're fine. Their language is fine. They're not going to be, well, they're going to be a problem, but they're not going to be the problem that I thought they were going to be.
Right. Wow. That was like so you can talk.
Yeah, that's a good one.
That is a really good one. Thank you so much for coming on again.
Welcome. You're welcome.
And are you committing to next season too?
You got to tell me a topic. What are we doing?
I know. I just jumped. I don't know yet, but thank you so much for being here.
I'll do another season.
Okay. Yes, good.
Season. All right.
Thank you for being here.
My pleasure.
To everyone else, thank you for being here with us, and take care, Mama.